Hi. Welcome to Dr. Vic's Academy. Today we will be talking about hypothyroidism. Hyperthyroidism is an excessive concentration of thyroid hormones in tissues caused by increased synthesis of thyroid hormones, or excessive release of preformed thyroid hormones. The common causes of hyperthyroidism are Graves' disease, toxic multinodular goiter, toxic adenoma, and painless thyroiditis. Graves' disease is an autoimmune disorder in which thyroid-stimulating antibodies activate TSH receptors, triggering thyroid hormone synthesis. Risk factors for Graves' disease include female sex, and family or personal history of an autoimmune disorder. Toxic multinodular goiter is the second most common cause of hyperthyroidism. Over time, nodules arise from the frequent replication of clonogenic cells that leads to a somatic activating mutation of TSH receptors. A single nodule is called a toxic adenoma. Painless or transient thyroiditis causes destruction of thyroid follicles via an autoimmune mechanism and a release of preformed thyroid hormones into the circulation. Elevated thyroid hormone levels amplify catecholamine signaling through increased numbers of cell surface beta-adrenergic receptors. The resulting adrenergic symptoms, for example, palpitations, heat intolerance, diaphosis, tremor, stare, lid lag, and hyperdefecation are the most common manifestations of hyperthyroidism. Hypometabolism induces weight loss despite an increased appetite. Neuromuscular symptoms include weakness of proximal muscles. Psychiatric symptoms range from anxiety to frank psychosis. Patients with long-standing untreated hyperthyroidism may develop atrial fibrillation or heart failure. Clinical suspicion of hyperthyroidism should prompt laboratory testing. Some physicians first order a TSH test, which has the highest sensitivity and specificity for hyperthyroidism, and then subsequently obtain free T4 if the TSH level is low. The serum level of TSH receptor antibodies helps distinguish Graves' disease from other causes of hyperthyroidism. A radioactive iodine uptake test and thyroid scan help determine the cause of hyperthyroidism. The uptake is very low in patients with thyroiditis, but high in patients with Graves' disease, toxic adenoma, or toxic multinodular goiter. The thyroid scan shows the distribution of radiotracer in the gland. A homogeneous distribution indicates Graves' disease. Accumulation of radioactive iodine in one area points to a toxic adenoma. If accumulation occurs in multiple areas, it points to a toxic multinodular goiter. Regardless of the cause of hyperthyroidism, the adrenergic symptoms are controlled by beta blocker, for example propranolol. Treatment of Graves' disease. Graves' disease requires one of the three treatment options: an antithyroid medication, radioactive iodine ablation of the thyroid gland, or surgical thyroidectomy. The choice of treatment depends on the benefits versus risks in a specific clinical situation and on the patient's preference. Antithyroid medications. Antithyroid medications are thalidomide. They inhibit thyroid peroxidase, thus blocking the synthesis of T3 and T4. Thalidomide can serve as a long-term therapy. Thiazide can also be a temporary treatment to normalize thyroid function before starting radioactive iodine ablation or thyroidectomy. This can prevent exacerbation of hyperthyroidism after radioactive iodine ablation, as well as avoid surgical risks associated with uncontrolled hyperthyroidism. Graves' disease remits in up to 30% of patients treated with thalidomide. Once medical therapy is discontinued, relapse occurs in 30% to 70% of patients, mostly within the first year. Because use of propylthiouracil has a higher risk of causing severe liver injury, methimazole is preferred. However, methimazole can cause birth defects in the first trimester of pregnancy. Therefore propylthiouracil is preferred during the first trimester. Radioactive iodine ablation. Radioactive iodine ablation is contraindicated in pregnancy. Pregnancy should be ruled out within 48 hours before radioactive iodine ablation and avoided for 6 months thereafter. Most patients develop permanent hypothyroidism between 2 and 6 months after radioactive iodine ablation, and require thyroid hormone supplementation. Thyroidectomy. Besides general anesthesia risk, thyroidectomy carries a risk of inadvertently injuring parathyroid glands and recurrent laryngeal nerves. Treatment of toxic adenoma or toxic multinodular goiter. Antithyroid medications can control hyperthyroidism, but do not induce remission of hyperthyroidism associated with toxic adenoma or toxic multinodular goiter. Therefore, radioactive iodine ablation and thyroidectomy are the main treatment options for these conditions. Thyroidectomy is favored if a nodule or goiter causes compressive symptoms. Painless thyroiditis and subacute thyroiditis are self-limiting conditions that usually resolve spontaneously within 6 months. There is no role for antithyroid medications or radioactive iodine ablation in the treatment of thyroiditis. Beta blockers may be used if needed to control adrenogenic symptoms. Pain associated with subacute thyroiditis may be relieved with a nonsteroidal anti-inflammatory drug. In summary, the most common causes of hyperthyroidism are Graves' disease, toxic multinodular goiter, and toxic adenoma. Hyperthyroidism can be treated with antithyroid medications, radioactive iodine ablation of the thyroid gland, or surgical thyroidectomy. The choice of treatment depends on the underlying diagnosis, the presence of contraindications to a particular treatment modality, the severity of hyperthyroidism, and the patient's preference.
Audio Jungle. Audio Jungle.